Okay, so we'll get started. And tonight we're going to just do one case, even though you have two specimens there. But it's a complete atrial septal defect with tetralogy. So you'll learn how to do a tetralogy repair. You'll learn how to do the AVSD repair, and you'll learn how to close VSD. So one heart, you can learn the whole curriculum of congenital heart surgery.
So can I ask you, the other people, can you hear us? Can you hear Dr. John Coles? Answer us, please.
You're muted.
Or muted?
Yes,
Yes, sir. Yeah, yes, sir. Can you hear us?
No response.
He doesn't have microphone. No.
Oh, maybe not.
Okay.
What about Miriam? Can you hear us?
Miriam,
No, Miriam is-
Chico,
Yeah.
actually, Chico's in a meeting and Miriam's
Miriam and Sachiko will be a little late.
they'll be here later.
Or are they doing a case in New York?
Yeah, I think Miriam might be doing a case in New York with the thoracoscopic case, and then Chico's presenting for.
Oh, that's right. The ex vivo heart or something like that.
Yeah.
I got an email from Masami. So okay, well then they can just see the video,
Yeah, they will look at the video.
and I'll just give a presentation.
Yeah.
We'll probably need another session anyway to do the other specimen at some point.
Yeah. Okay.
So so we'll go through the video, and I think you can see get a really good understanding thanks to Pam's 3D recon. You get a very good understanding of the morphology of the VSD, because that's sort of the principal component of the operation, and as it is many operations in general, it's VSD. So okay, look who's here. Wow. Yeah, no, thanks for coming, guys. We're just getting started. I think, is Miriam still in the OR?
She's probably,
Yeah.
she's,
Yeah. Well, anyway, well, they can watch the video. So I was just saying that tonight we're going to do the session of AVSD with tetralogy. One specimen is more than sufficient for tonight, because they'll get an understanding of tetralogy, VSD, and complete AVSD. So they can repair this heart. That's basically the complete curriculum of congenital heart disease. We can all go home tonight as experienced surgeons. So again, thanks to Pam for these beautiful 3D recons showing the heart. Without the three dimensions, you really can't get an appreciation of the anatomy of the VSD. I would also direct you to Shiju's article in Circulation Imaging a couple of years ago, because it's very focused on surgical planning and double outlet right ventricle. And I think this case is really merges into a double outlet right ventricle. And Pam, what's the definition of tetralogy where it transitions into a DORV? Do you think? Yeah. Yeah, exactly. So that's what I usually rule of thumb that I rely on. So I'll go through the video and I'll stop at various parts that I think are worthwhile to enhance your understanding of the anatomy. You might need to help me now.
Yeah,
Okay.
yeah, I can.
Okay, so this is interesting because you can see the ventricular septal defect here. In double outlet right ventricle, it's really a reciprocal relationship between the caliber of the pulmonary outflow tract and the aortic outflow tract. So you have a bigger, there's only a fixed amount of real estate there. So if you have a bigger subaortic outflow tract, the pulmonary outflow tract is going to be compromised. And that's especially true when there's complete AVSD because the great vessels are so-called sprung. So they're not situated in between the AV valve leaflets, but rather they're elevated out. So in this specimen that you'll have, you can see that the right outflow tract is very narrow. When you start on your specimen, I'm going to take down the pads that I did in the movie. And while you're getting started, and the first thing I'll get you to do is to resect the right atrium, the front wall of the right atrium. So I found when I was doing that, it was just easier to get access to the vent. So you can do, that'll be the first thing that you do. The second thing is to make a long right ventricular outflow tract transanterior incision. So extend it onto the ventricle about a centimeter, approximately. So in other words, recreate this opening here. Okay. So we were talking about this earlier, and as Pam pointed out, when the override of the aorta is 50% or more, it's semantically referred to as a double outlet right ventricle with subaortic PSD. And one of the interesting things that I think was nicely pointed out by June's article that I had a chance to read the other day is that the infundibular septum, which I'm pointing to here, when that fuses with the anterior limb of the TSM, this is the TSM, tracheal septum marginalis. So when the infundibular septum fuses with the leftward extent of that, you get a subaortic defect. So I see that nicely in this heart. And the other thing to point out is that in the usual complete AVSD, normally connected great vessels, you have an elongated subaortic outflow tract, so-called gooseneck deformity. And what you see here, because it's a double outlet configuration or tetralogy, is that the subaortic area shown here, so the direction of blood flow shown by my cursor goes from the left ventricle into the aorta, so it's relatively unobstructed, so you don't have to worry about obstructing the left outflow tract in general. This arrangement as we do in this heart. So the first thing we're going to do after you open the right atrium and make the incision in the outflow tract is to draw up a line. Pam's done a better job here. It's easier to see. A dotted line where you're going to septate the AV valves. And what I use as a marker for this, in my mind's eye, I don't usually use the ink pen because I find it's just blurs, diffuses in the heart, so it's hard to see. But in my mind's eye, I make a dotted line, sort of septating where I'm going to septate the heart. And that dotted line really follows the interventricular septal crest. So as long as you follow that interventricular septal crest, you won't go too far wrong in terms of having a disproportionate amount of left or right AV valve. So I find that to be a good marker. Now in this case, it's kind of an exception, of course, because since it's a tetralogy, there's rightward rotation of the aortic root. So actually the dotted line would go this way, but we don't want to do that because that would compromise the right AV valve. So we'll just take it as a continuation of the inferior bridging leaflet dotted line, and that's where our proposed septation of the heart will be. The other thing to point out is that the suture line will go rightward of the AV node So the distance here, I try and aim for 5 to 8 millimeters so that we don't suture in the AV node to cause complete heart block. I actually made a mistake here. The AV node should be where my thumb forceps are. Try and get in the habit of not grabbing the AV node. For some reason, when I'm working with the fellows, when they're just starting, first thing they want to do is pick up the AV node. So obviously you don't want to suture that, and you don't want to pick it up with your thumb forceps. So you like to spend, up to 5 minutes inspecting the anatomy so you understand what you're going to be doing. Since you guys are not necessarily experienced with that, you can take longer. And the next step, and I'll go through this with you, I'll sort of work on this specimen alongside of you at the same time to remind you what the steps are. But here, I think I'll get you to divide this leaflet. Normally, in a patient, we don't divide the leaflet. We did a study 8 or 10 years ago showing that when we divide the leaflets, it actually makes it easier to close the VSD, but there's a slightly higher incidence of dehiscence of the leaflet when you divide it, so we don't do that. But in this model, I'd like you to divide this anterior bridging leaflet so you can see the margins of the VSD. Otherwise, it's very difficult to see because when I did the VSD closure, I had trouble seeing it myself. I think this video is only about 5 minutes long, so don't worry. So I'm just trying to inspect the subaortic region. So now we're going to put the VSD patch in, and this is where the 3D recon is very interesting, very helpful, because we can now see the shape of the VSD patch. And I'll scroll through to show you this, and it's not two-dimensional. It's not a planar patch like it would be in a perimembranous VSD or even in a complete AVSD without tetralogy. So you can get the idea here, looking at the dotted lines, where you see that there's in effect really 2 dimensions, so that the patch takes up space on an X, Y, and Z dimension. And I know Asami has a method that recognizes the 2 dimensions that you're dealing with by using 2 separate patches. I think it can also be done with 1 patch, as we're doing here, but again, taking into account the fact that it's a 3-dimensional structure. And I don't know, do you think it would ever be possible to print a patch?
Oh, yeah.
Yeah.
Yes.
Because I know you were working on that with
Brenda.
the Norwoods, right? So it's the same principle. And so in other words, you could design a patch that's specific to the patient that you're operating on, but I'm not sure the consistency and the compliance of the patch.
Yeah, I think with time, with experience and the better logic,
Yeah.
and then we'll be able to get the really most ideal patch shape.
Yeah.
Yes.
So I'll show you an approximation of the old school way of doing
Honestly, that's what I'm really encouraging Brandon to do as an engineer.
Yes. So that I think as I scroll through there's a picture here that a really nice idea of the patch there. So you can see in this view, I like this view because you can see how the patch flares here to accommodate the aortic valve here. See that it's really in 2 dimensions. So even for me, it really helps me understand the definitive shape of the patch that we're going to try for. So this is sort of my old school approximation of the patch without using any software. And so the patch is comma shaped, as it would be for the usual form of complete AVSD. But here, this dimension depending on how much override there is roughly the diameter of the aortic valve, plus an additional small amount to allow for sewing. So this dimension here is more or less equal to the diameter of the aortic valve, given that there's about 50% override. And this is the atrial margin of the patch. So when we're inserting the patch, I can never get the patch perfectly sized before sewing it in. So I usually make two trimming adjustments to the patch size. One here, so we resect this part to reduce the atrial margin length. And the second one is typically this height will be too much. So when we're putting it in situ, and you'll see this in the video, we'll resect some of the height so that it fits nicely under the AV valve leaflets. So when you cut your patch, try and think of this comma-shaped design, where the atrial margin is equal to the distance between the anterior and the inferior bridging leaflet. So again, we'll go through these steps as you're doing it. So to remind you. So always, after you make the patch, always try it on for size. Stick it in where you think it's going to sit to find out if it's in the right ballpark. So here we're starting the suture, which is essentially the same for VSD or tetralogy. So this is very much like a tetralogy repair without the resection of the outflow tract. So start more or less at the nadir of the septum. And usually put in 2 or 3 sutures, 3 or 4 sutures before pulling down. But in these models, suture doesn't pull through quite as well. So we'll bring the patch down after putting in 2 sutures. So we're marching along the crest of the ventricular septum. At this point, of course, there's no conduction tissue, so you can actually circumscribe the margin of the ventricular septal crest with the generous bite without worrying about the conduction. So we'll put the patch in place. And it's better if you have an assistant. And so we're just marching up the septum, and you can see that the white structure, which is the aortic valve, will come into view. So we're going to place our sutures close to the anions, but obviously not through the valve. So in this case, we've done something a little bit different, which if you make that incision in the leaflet that I was talking about, you can probably see the VSD close it completely working from the right atrium. But I'd like you to have a look at it through the right ventricular outflow tract, just so you can understand the anatomy. That's what we're doing here. I found it easier to sew this part of the patch working from the right ventricular incision, so we've done that. So this part of the septum, I would call that the ventricular infundibular fold. Is that correct? This part of the septum, the muscle between the tricuspid valve and the aorta. You refer that morphologically as the right infundibular.
If there is,
Yeah.
but in this case, that I think the aortic valve and tricuspid are in direct contact. So in this case, I would say there is absence of VIF.
Okay,
Yes, and then which means that there is no subaortic infundibulum.
right. So, so we're completing this part of the VSD through the right ventricular incision, and then, so remember I said we're going to trim the patch in 2 places. So here we're reducing the length of the patch, so it fits under the AV valve leaflets. Okay, now at this point, now we're just continuing as we would with the perimembranous defect posteriorly towards the crux of the heart. And you can see now that the sutures are exiting a little bit rightward of the crest of the septum because we don't want to impinge on the conduction tissue. bring the suture line to the junction of the posterior bridging leaflet and ventricular septum. So that this suture line, suture goes underneath those chordae. I don't know if you can see that on that. But you want to take the suture line underneath those chordae so that the patch gets tucked underneath those chordae. Show that with the Hanjo suture in a minute. So we've completed that suture line. Now this is the suture I refer to as a Hanjo suture. He tells me it's the Van Arsdale suture, whatever. But I think it's an important suture because this is one of the areas that's notorious for getting a residual defect, is right in here. And I think it lowers that risk by putting a pledget supported mattress suture right here. It also has the effect of shortening the free margin of the atrial margin of the patch, because you want that margin of the patch fairly short so that there's no tension on the bridging leaflets. And I'll point that out, just get a better idea of that in a minute. So the first limb of the suture, you should take your time doing this suture because it's probably the most important suture, I think. Goes from the right ventricle underneath the chordae and then catches the corner of the patch. See that right there? That bite. Okay. So we then bring the other limb of the suture into the atrium, typically catching some of the ventricular septum if we can see it, and then going through the leaflet. Now I realized I made a mistake here, and I went through into the atrium proper. Typically, I try and go through the base of the leaflet, just so there's no risk to the AV node. So then you put a pledget on it and bring it then back in from the atrium to the ventricle. And watch as we go through the patch here. So you can see that suture in the patch has the effect of shortening the free margin of the patch. So that when I tie it down, so I think you see that effect as we tie these. I always tie these sutures to get them out of the way, otherwise it's too confusing. There's too many sutures in the way. So I tie them and cut them. So you can see that that had the effect of making this distance shorter so that the overlying leaflets wouldn't be under any stretch. And I think you can see that here. This is the superior bridging leaflet, the inferior bridging leaflet, and this is the so-called zone of apposition between the superior and inferior bridging leaflets, which is always referred to as a cleft. So basically that's the VSD. Now we have to do the ASD. Actually, we're gonna, first thing we do here is to close the base of the cleft so we know how the leaflet is gonna, the common leaflets are gonna be partitioned. It's just checking it from the right ventricular side. This suture shows a transition at the anterior extremity of the defect. Mattress suture to secure the VSD patch to the junction of the superior bridging leaflet and the annulus. So again, tie the suture down. Tie it to the continuous VSD suture. So now we're doing the ASD patch. And the reason this is called a sandwich repair, a lot of people refer to it as a sandwich repair, is because you're sandwiching the AV valve leaflets between the VSD patch below and the atrial primum pericardial patch above. So a sandwich type effect. And you can see that these there's no tension on these leaflets because the VSD patch is not too long in this dimension. So the first thing we're going to do is close the base of the cleft so we can then partition the leaflets in an AP dimension. Close the base of the cleft. And take those limbs of the suture through the base of the pericardial patch used to close the atrium. And then, before we do that, we'll close the cleft. First suture, I try and put in the apex of the cleft so that it lines up. And what you're looking for to make sure you haven't made a mistake is that these two dimensions are roughly equal. So if one of the lengths of the leaflets, either superior or inferior, is much longer than the other, then you distort the leaflet. So that's something to look for. So now we're doing the sandwich suture, ventricle patch through the AV valve leaflets and then through the ASD patch. So this is now the ASD patch. I'm not going to show all the sutures here because it's tedious. Normally in a patient we wouldn't leave gaps, but the suture is 3 to 5 millimeters apart, but here I've left gaps because probably we were running out of sutures. Kevin was getting tired. So now we're securing the inferior part of the patch. And now what's left to do is to close the atrium. This atrium you'll see is a huge atrial defect. It's essentially a common atrium. So we're going to partition it with the patch, and I'm not going to show all the suture line. We just did part of the suture line to show you how it where it goes. Normally this would be pericardium. So there we are there. So that's all we're going to sew the atrial patch. Make sure when you're doing the atrial patch, it's a little bit confusing. Make sure you know where the IVC is going to drain. So that, what I didn't show was we then close the cleft on the right AV valve. There are typically 1 or 2 sutures because there's effectively a cleft on the right side. That helps with the confidence of the right AV valve. Okay, so this one we're just sort of playing around with, and we wanted to. Normally we just do a transannular patch, same we would do in a usual tetralogy. Here I wanted to use the proximal pulmonary root as a neo-pulmonary valve, with the idea that you won't be doing that here tonight. I was just playing around. One of the things that I like about June's model is you can just play around with stuff that obviously you can't do in a patient. So there's the incision. So in this case, just make an incision into the branch pulmonary arteries. And then the key step here is to divide the main pulmonary artery. I'm sort of dividing it halfway along. So you can dial in the length of the leaflets you want by taking that incision either closer to the valve or closer to the bifurcation. That will dictate the length of this leaflet. And for a normal pulmonary valve, there'll be a distance, I don't know what it is, but coaptation between the leaflets. So in diastole, you want the leaflets to overlap so they don't prolapse back into the ventricle. So you have a depth or distance of coaptation. I'm not sure what that is in a pulmonary valve. Obviously, it's going to be age dependent, but you can dial that in based on where you made the division. So what the plan is here is to use the proximal pulmonary root as a neo-pulmonary valve. I don't know whether it would work or not. The theoretical advantage is that it's vascularized and cellular, and therefore should be resistant to degradation. Disadvantage of it is that exterior part of the valve would have adventitia on it, so it could be thrombogenic. It should get washed with every cardiac cycle. Then we take the distal pulmonary root that we divided and bring it down to the pulmonary annulus, thereby telescoping the root or the neo valve into the pulmonary trunk. So the first thing, so what we do is the problem with the light, but, connect the distal pulmonary root to the annulus without circumscribing the LID. So that's what we're doing here, attaching the pulmonary root to the sort of distal pulmonary artery to the pulmonary annulus. So Kevin's, where it gets really smooth and slick is Kevin. This is Kevin here, bringing down that side of the root, just the pulmonary artery to the pulmonary root. Bring it down onto, see the junction of the right ventricle and the pulmonary annulus.
That's crazy.
Yeah. So now, because we've made a transannular incision, there's a deficiency of the anterior leaflet. If it was a normal size annulus, you could do this, or the large annulus, let's say after a TOF repair, where there's pulmonary insufficiency, you wouldn't need to do this. But in this case, we need to make an anterior leaflet. So we're attaching this patch to the residual pulmonary trunk. This will just take a minute because it's basically just suturing. Tie those two together. And we'll do this. Other side. So this will be the anterior Neolithic interfaces with the proximal pulmonary trunk forming the other leaflets. So when we're doing this, you can make the width of the patch and dial in any Z value. Typically, we aim for a Z value of +2 in a right ventricular contract patch. So that's what we would do here. Tie this. One thing I realized I have to work on my precision. You can see Kevin's suture line. It's perfect. My suture line, it's like I had a couple beers or something before. So that's something when you're working on these patches, you can actually can't do it in vivo as well. It's the tissue, but you can work on your precision looking at your suture line. And bringing that just down to the right ventricular incision and tie it. Just about finished. I didn't realize it takes this long. So what we need to do then is make 3 commissures. So this suture line goes through the pulmonary root and through the posterior wall at 6 o'clock of the distal pulmonary trunk. Mattress suture forming one of the 3 commissures. Otherwise, the leaflets will prolapse back into the ventricle, right? One of the things we're not, it's unknown is whether there'd be so much stress on a single suture line that the commissures would tear apart with time. Commissure at each of the lateral extremity of the leaflet. This is on the left side. Right side. with one more suture on the right side. So there's 3 commissures like a pump valve. See that in the view from above. I guess that's when we have the light. That's why you're saying don't use
Yeah.
the light.
Mhm.
So this shows systolic position leaflets. 1, 2, 3. These will be the sinuses. And yeah. So the new valve basically is created from the previous pulmonary root. One of the things you'll find when you operate on these patients is the pulmonary artery wall is very thin. It's actually thinner than the leaflets if there's any leaflet thickening. So, but that's one of the things we don't know what would be the impedance to flow. So that's the systolic position of the leaflets. And then let me run through this.
Mhm.
Press forward to the last image. So we're just putting a patch on there just to reduce the tension because so you don't need to do a Lecomte because you're bringing distal pulmonary artery down to the ventricle. So this suture line is just like you would do for a prosthetic pulmonary valve. You bring the patch down, sewing it to the base of the leaflet. Sorry if it's taking so long. I thought it was only about 5 minutes long. Okay, so this is the same suture line you would do in a prosthetic pulmonary valve implant, right? So suturing the patch to the ends of the valve. Normally we would have a longer patch to extend down to the right ventricle, but just for purposes of illustration, we didn't do that here. Same thing on the other side.
Mhm.
You fast forward to yeah. Okay, so then this shows the diastolic position of the leaflets. So there's 3 cusps. This one is a neocusp because we had to enlarge the outflow tract. The other 2 cusps. So this patch, this part of the leaflet would not be vascularized, so it could be subject to degradation. Okay, so while you're going to your stations, and I'll go through the stages of the repair with you.